Welcome to AETCM, the Emergency Medicine Channel. 55-year-old female patient came to ER with a complaint of acute onset of central chest pain since 4 hours. Initial 10-second assessment, patient was conscious and oriented. Coming to primary survey, airway was patent, there is no pooling of secretion, no gurgling of sounds. On breathing, respiratory rate 18 per minute, saturation 100 room air entry bilateral equal. Coming to circulation, heart rate is 90 per minute, BP was 120/70. Disability wise, GCS is full, 15/15, people's bilateral equally reactive to light. Exposure part, GRBS is 310 and temperature was normal. To advance to primary survey, we taken an ECG and a point of care tropi. ECG showing T inversion in 2-3 AVF and V4 to V6, and tropi came to be positive, sir. Then we can send a routine blood investigation.
Go ahead with the sample history.
Sample history. Coming to sample history, there was no any allergic history. Patient was non-case of hypertensive and diabetic. Last meal taken on 3 hours back. A patient presented to ER with complaint of central chest pain since 4 hours, which was acute onset, throbbing in nature. Pain was radiating to neck side and right upper limb associated with profuse sweating. And patient had history of exertional dyspnea and chest pain since 4 months, which was relieving by rest. No history of palpitation, breathlessness, loss of consciousness, vomiting, no history of fever, cough. There is no history of PND or orthopnea. On general examination, there is no pallor, ictus, clubbing, cyanosis, lymphadenous edema. Serious examination, heart rate is 90, BP 120/70, no added sounds. Other systems are within normal limits, sir.
So what's your diagnosis?
By symptomatically, patient comes with chest pain with our.
What is your diagnosis?
At present, diagnosis unstable. ECG changes with the tropi. It is NSTEMI.
Okay.
ACS with NSTEMI.
So acute coronary syndrome, non-ST elevation MI. Whether the patient is in sinus rhythm or not in sinus rhythm.
Sinus rhythm, sir. No
failure or not in failure.
Not in failure, sir.
Not in failure. So that is your diagnosis. So we have a patient, 55-year-old lady, who has come to the ER with 5 hours, almost 4.5 hours onset of central chest discomfort. So what are the important things? You will start with airway. Okay. So what are the problems that you can anticipate in airway in a patient that is coming with chest pain? I'm not saying regarding an ACS. A patient with chest pain has come to the ER. Airway issues, what all things you will anticipate?
Airway, chest pain, if there is any.
So what are the, in brief, what are the life-threatening causes for a chest pain?
Pneumothorax.
And when you take behind it, you will get the answers.
Pneumothorax, attention to pulmonary edema, foreign body.
ACS relating to a pulmonary edema, and patient is having this thing. So what you will get in pulmonary edema?
Frothy.
You will get a lot of secretion. So usually airway challenges, usually what we will face is a lot of secretions you go and have, like pink frothy sputum, or you can have sometimes hemoptysis with chest pain. What all things you will suspect?
LRTI with pulmonary chest pain.
Pulmonary edema can also very rarely can cause with the mitral stenosis. They can have then aortic dissection. They can sometimes, very rarely, but they can still present. So these are our concern. Pulmonary embolism, that is the other differential diagnosis. But this lady is an acute onset, 5 hours of pain. So anticipation in her, she is otherwise stable, airway is patent. Coming to the breathing, what all, again, oxidation issue. So whether there is a still lot of confusions in people's mind, what is the saturation target that you wanted? Previously, whenever we read regarding MI, what is the mnemonic that you have all learned? Morphine, oxygen, aspirin, and nitrates. MOA. That was the mnemonic that we all learned. So what is the role of oxygen in case of an myocardial infarction for this patient?
If there is desaturation, we will target.
No, not desaturation. You should be
target saturation is more than 92.
What do you mean by desaturation? There is no definition as such for desaturation. You have to say hypoxia or not having hypoxia. So when will you say it's hypoxia?
At POT less than 60.
So when does that happen?
Less than saturation 95. SPO2 less than
90. So when PO2 of 60 is equivalent to an SPO2 of 90. Okay. So when you have And myocardial infarction, what is your target saturation?
More than 92 SpO2.
95%. If the oxygen is above 95%, you don't need to start him on oxygen. So that is the first thing. All patients with myocardial infarction doesn't require oxygen. Target is 95%. If the oxygenation is above 95%, no need to start on O2. If it is below that, you start on O2. That's maybe a mild hypoxia, maybe 70, 75. You can take it as normal. PO2 60 is for critically ill patients. Okay, for an ICU patient with ARDS 60, you are okay with it. For an otherwise, for you, if you check a PO2, if it is like 60, it is not normal for you. It should be somewhere around 80 to 100. So if it is less than 80, the saturation start falling below 95%. So that is what we need to take in. We need not treat all patients with chest pain with oxygen. So unwanted free radical injury, everything is happening. So that is the consensus. Only if saturation falls below 95, you start them on oxygen. That is regarding your oxygen requirement. Then coming to circulation. What are the problems that you commonly anticipate in a patient with chest pain in circulation? You can have blood pressure and heart rate. So heart rate and blood pressure, what are the most commonly seen things, and what all you can anticipate?
Patients have high BP, elevated blood pressure and tachycardia. In inferior MI, there is bradycardia, you can see.
Not in all inferior MI, you won't get bradycardia.
Right
Not in all right ventricular MI also. If it is
SA node affecting?
If SA node is getting affected, it's a right dominant lesion with RCA that is supplying the SA node. Then you can, if it is an LCX lesion, then only you can have. So whenever SA node is affected, you can get bradycardia, heart blocks and all those things. So tachycardia is the most common finding. You can have arrhythmias also. Very rarely. Why an arrhythmia is getting formed?
Because of MI necrosis of the cardiac tissue, causing that tissue producing the impulse, causing the arrhythmia.
So what type of arrhythmia is very common? What type of arrhythmia is common? Do you see a lot of atrial fibrillation, or you will see a lot of something else?
Atrial
You don't see atrial fibrillation. We see ventricular arrhythmias. We see a lot of ventricular tachycardia and ventricular fibrillations. In myocardial atrial fibrillation, where you will see commonly atrial fibrillation?
Hypoxia.
Hypertension. When you have a chronic hypertensive patient or mitral valve stenosis patient, left atrial dilate, whenever there is a atrial pathology only, you will have atrial fibrillation. Whenever you have a ventricular pathology, ventricles is getting affected and scarred, usually in MI, you will get more of ventricular arrhythmia. So that's the most common presentation that you will see. So you can have tachyarrhythmia as well as bradyarrhythmia. You can have heart blocks and all those things. And again to the blood pressure, most common is hypertension, but you can have hypotension also. So hypotension, how will you manage with a patient with MI?
Fluids.
Fluids you will give? Not for every hypotension. When it is a right ventricular MI infarction causing hypotension, fluid is the treatment. But other cases, you need to start them on
chronotropic agents.
Inotropic agents. Inotropic agents. You need to start them on inotropic agents, and depending upon the blood pressure, you need to decide 90/60, below 90/60, above 90/60. So 90/60, then you can straight away start them on drugs like dobutamine, which can increase the contractility of the heart. But if it is below 90/60, you need to start an alpha blocker. You need to start an alpha blocker like noradrenaline. Then only you need to build up. When you technically speak, what is happening? 80/60, 70/60, you start dobutamine. Again, the dobutamine can cause peripheral vasodilatation and further dropping of blood pressure. But that is the reason why you need to improve the blood pressure above 90/60. Then you add on dobutamine. Any role for NTG?
NTG, it will decreases coronary dilatation.
I'm telling the patient is having one limb 120/60 BP. You are giving dobutamine on one side and you are giving NTG on the other side. How does nitroglycerin help in your myocardial infarction?
Vasodilatation versus coronary dilatation and supply.
Coronary dilatation is one thing. How does else it will help? Decreases the preload. So it decreases the preload. So that is why. So sometime when we say this patient, you usually start NTG for your hypertension management. But hypertension is not only for also for preload reduction we can start. So not just for your hypertension. So that's the difference. So you can anticipate hypertension, and where will you avoid NTG?
In bradycardia and hypertension, we will avoid NTG.
Why?
Because cause hypertension and
why?
Decrease the preload and output decreases.
So what type of MI? All bradycardia you will
right ventricular RCA MI causes
right ventricular myocardial infarction. Right ventricular myocardial infarction. Where else you will not give nitroglycerins infusions? MI, you said RV MI, you will not give. Then Where all it is contraindicated.
Patients in taking phosphodiesterase inhibitors also
Okay.
nitrogen
Okay, then.
contraindicated.
HOCM, not HCM. HOCM,
Obstructive-
hypertrophic obstructive cardiomyopathy. Then severe aortic stenosis. These are the conditions where you should not be using your nitroglycerin. So these are the other most common being RVMI and HOCM, not HCM. I am saying HOCM, hypertrophic obstructive cardiomyopathy. So and these things you preferably not to use nitroglycerin again due to the same reason what we have said. So that is regarding an ABC circulation. Now you go ahead and take an ECG. So how will you diagnose an MI? How will you diagnose an MI in the emergency room?
ST elevation,
Not in the ECG. How will you diagnose in general? Three things that you need to remember: history, ECG, cardiac enzymes. So these are the three things: history, typical history, or you can sometimes get atypical history. So that we can say MI equivalence. I'm not saying the ECG. MI equivalence. What are the symptoms that we can take it as MI equivalence?
epigastric pain,
Epigastric pain, okay. Vomiting,
lower abdominal pain,
lower abdominal pain, not very common. Then
Jaw pain.
that's all typical only, you know. Syncope. That's how one. They can have heart blocks and they can come with syncope. First MI that I have seen in my ST elevation MI, I had seen the patient presenting to a syncope, an inferior wall ST elevation MI with bradycardia. So syncope was the presentation for me. So all those things you need to keep in your mind, especially patients with multiple comorbidities, diabetes and all. They will not have the typical classical presentation. So that's the symptom that you need to consider as equivalence of myocardial infarction. So you've taken an history, then you have taken an ECG. So on ECG, what are the things that you need to look in for?
ECG for teen versions.
No, what are the things when generally a patient coming with chest pain to the emergency room? You can have different reasons for chest pain. So what all idea that you will get from ECG?
Look for ST elevation for.
So commonly you look for ST elevation. Okay. So what is a significant ST elevation in an ECG?
More than 1 millimeter elevation concurrent chest leads.
1 mm in chest leads.
0.1 millivolt. That is 2 mm.
So in limb leads it is 1 mm and in chest leads there are AHA has come up with different guidelines. For young males they have taken it as 2.5 mm and for others they have taken 2 mm. But in general you remember more than 2 small squares. More than 2 small squares and should be in the concordant. It should be not the concordant, it's in the consecutives, nearby leads, which is the representing that specific area. And sometimes you will get reciprocal changes. Not for every cases you might get reciprocal changes. Sometimes you will get, when there is an ST elevation in anterior wall, maybe inferior wall, you will get ST segment depression. So sometimes you will get, sometimes you won't get. So you are primarily looking for an ST elevation. Then what are the other things? STEMI equivalence. So when you see this, okay, this we need to treat like an ST elevation MI. These are all STEMI equivalents in ECG.
New onset of LBBB.
New onset LBB, then
Early repolarization.
early repolarization is not a STEMI equivalent. Then AVR ST elevation.
AVR elevation.
ST elevation of AVR 0.5 mm or more than 1 mm, it's significant proximal LAD occlusion. So AVR ST segment elevation is very true posterior wall MIs. Or you don't see ST elevation, you see ST segment depressions.
V1
ST segment. So true posterior wall MI, that is again STEMI equivalence. Then what is D Winter sign? Wellen syndrome.
Wellen syndrome, biphasic wave in V1, V2.
It should be T wave inversions. So it's Wellen syndrome and all, it's STEMI equivalence. So you have to take it as D Winter sign also, you need to take it as STEMI equivalence. So these are the ECG that we have to say. AVR ST elevation. Most commonly you have to look for AVR. AVR you are saying in ST elevation, that is a STEMI equivalent. So you need to treat how you are treating a STEMI patient. So LBB, as you said LBB, then true posterior wall MI, D Winters and Wellen syndrome. These are all STEMI equivalents that you need to consider. Okay, so that's your ECG. Then ECG, what are the other things that you can get in the ECG?
In chest pain, we'll rule out S1, Q3, T3.
What will be the first finding for an acute myocardial infarction in the ECG? How does the ST elevation or how does the whole thing evolves?
T wave, upright
Hyperacute T wave. That will be the first thing. Hyperacute T wave followed by ST segment elevation. Then what will happen to the Q? There will be Q wave formation. If you are treating well, there should not be any Q wave formation.
Full
Q wave
damage,
formation. What is the
complete
significant
damage
Q
of
wave?
microbial
What is
tissue.
significant Q wave?
More than 2 box.
You have to consider the preceding QRS complex. If it is more than 1/3, it is a significant Q wave. Okay, so QRS, there will be a QRS complex that is formed. R wave is there. So if the length of the dip of the Q wave is more than 1/3 of the height of the R wave, you can take it as a significant Q wave. That is only a significant Q wave. So Q wave formation means there is an infraction. Then what can happen to the ST elevation? Usually what will happen ST elevation, sometimes it will remain and sometimes it will settle and there will be T wave inversions. So this is the usual one. Once you treat it properly, what will happen? There is no Q wave formation. ST will come back to the normal baseline if there is adequate treatment being given to that patient. So the same patient is coming back to you and he has got a persistent ST elevation, but he is not asymptomatic. What do you suspect?
With cardiac and negative.
Patient had an MI, he had an ST segment elevation. Now he is coming back to you. You have taken an ECG. There is no chest pain for the patient, but there is persistent ST elevation. What will you suspect?
Cardiac and
Persistent ST elevation is LV aneurysm. You have to suspect a left ventricular aneurysm. When you have patient is having a persistent ST segment elevation, you have to think of LV aneurysm. Okay. Then what are the other causes of ST segment elevation? You have 14 to 15 causes for ST segment elevation when a patient comes to the ED. So 1, 2, 3, 4, 5, 6. You can elaborate.
One is MI.
ST elevation MI.
New onset of LBBB.
New onset LBBB.
Left ventricular aneurysms.
Left ventricular aneurysm. Okay. Left ventricular hypertrophy.
Hypertrophy.
The early repolarization pattern.
Repolarization.
Then posterior defibrillation. You can have ST elevation in the ECG.
Princemetal angina.
Princemetal angina. What is princemetal angina? Basically,
coronary
it is
vasospasm.
vasospasm. So once you give nitrate, it will settle back to normal. Then other. I'll give you a clue. This patient has got a family history of sudden cardiac death.
Brugada syndrome.
Brugada syndrome. Then the patient has come with a fever with chest pain.
Myocardial.
Pericarditis, most commonly pericarditis, ST elevation. I think we have told some 10 causes of ST segment elevation. Then pulmonary embolism, very rarely pulmonary embolism, but the classical is the tachycardia and the McGinn-White sign, S1Q3 T3. You will have 30. It's not specific, but you can see S1Q3 T3 also. So these are the most left ventricular hypertrophy. I think we have covered left ventricular hypertrophy, post defibrillation, then paced rhythm. That is the other reason. You can have when the patient is on a pacing rhythm, you can have ST elevation. So paced rhythm also you can have ST elevations in the ECG. Then other causes. I think that's what I remember. 11 to 12. I think there are 14 to 15 causes for your ST elevation. You should remember that when you are writing, when you are seeing the patient specifically. So that is your ST elevation. So now what are the things that you will consider as non-ST elevation in the ECG? You said this patient had some findings. So anything other than ST elevation, you take it as non-ST elevation. So what are the things like ST segment depression,
T inversions.
T inversions, and a normal ECG. You can have a normal ECG also. Then what will be the only difference? They will have positive cardiac biomarkers. So when you say ST elevation MI, non-ST elevation MI and unstable angina. ST elevation MI, it's purely your ECG diagnosis and there will be history. Cardiac enzymes, any point in sending cardiac enzyme, no. Because if it is more than 3 hours to 4 hours, only you will get elevation. But again, you are saying ST elevation, no need to wait for cardiac enzyme. But cardiac enzyme also will be elevated. So all the three will be positive. Your history will be there, your ECG findings will be there, and you will have a positive cardiac biomarkers. Non-ST elevation MI, you can have ECG changes, but definitely cardiac enzymes will be positive and patient will have symptoms. Unstable angina,
ECG changes will be there, cardiac enzyme negative.
ECG changes may not be there, cardiac enzymes will be negative, only you're diagnosing with your history. So what is the three things, what is the pathophysiology behind these three? ST elevation MI, non-ST elevation MI and unstable angina. What are the? You can tell.
in ST elevation MI, there is a rupture of the plug and thrombus formation causing transmural obstruction. In STEMI, there is a plug rupture and subendocardial obstruction is there.
The complete endocardium is not damaged. Only the subendocardial area is damaged. But since the endocardium is getting affected, your cardiac biomarkers will get positive. So that is your difference, major difference. Unstable angina?
No, there is no obstructions. There is obstruction is there. There is no complete blockage of the.
No, the problem in unstable angina is on the other side, demand has increased.
Demand increasing. Exertion
Demand has increased. You have anemia. You have fever. The demand has increased. Normally, there is a fixed obstruction. For a normal day-to-day activity, that is okay. But when demand increase, that is not meeting. So within 4 weeks, there is a new worsening of the class of breathlessness, class of chest pain. You can call it as unstable angina. Then what is the other problem? A small plaque can get ruptured and can cause an obstruction, but it's not causing any myocardial infarction. Then, as you said, vasospasm. So these are the reasons. Vasospasm, once you have a principal angina, transiently when you take an EC, you might see an ST elevation. But you give a nitrate, everything is settled. So you have to treat like an unstable angina and principal angina for that group of patients. So demand has increased on the other side, and or else a new plaque ruptures has occurred, or there is a coronary vasospasm. So why we should know this pathophysiology? This is how the treatment is being planned. How you need to treat the patient. Why we are only doing PCA and thrombolysis for an ST elevation MI. We are not doing thrombolysis for a non-ST elevation MI. Is the reason is behind this. There is a new thrombus formation. When you have to give an multiplacid drug, that should lyse a newly formed clot only. A chronic clot, a calcified is not going to help you. Or maybe a small thrombus, it's not going. Its benefit is less as compared to the risk. So that is why you are not thrombolizing in your non-ST elevation MI. And in unstable angina, it's a chronic problem. The patient might be having day-to-day activities okay, but when he is climbing stairs, only he is having chest pain. But right now, what has happened is class have changed because of fever, sepsis, or some other reasons. So the demand has increased. So we need to correct, or maybe anemia. So the oxygen that is reaching the heart is decreased because of the anemia. So we need to correct that anemia. So that is how we have to plan the treatment for these 3 groups of patients. Okay. So now, how will you interrupt your cardiac biomarkers? How will you infer the report of a cardiac biomarker? Somebody is coming and telling you, sir, this is the troponin I of this patient. So how will you infer that cardiac biomarkers?
Troponin will elevate more than 4 to 6 hours. It would peak on 12 hours, and it is decreased by 7 to 10 days. CKMB elevated by 3 to 4 hours, and it is coming to normal range within 24 to 48 hours. So for this patient, acute onset and trop is elevated within 4 to 6 hours. We can tell if this patient is going to end-STEMI.
Okay. Then how will you? What are the other biomarkers that you can use?
CKMB, TROP-I.
Where else you can have TROP-I and TROP-T elevation? See, there are now correction factors that have come for. There is a newer update that is coming up for renal failure and all. There is a correction factors they are bringing in. So if you say something like very high troponin I, and I'm not very sure what is the correction factor. They have a new formula, like we have corrected BNP for the age. For every age, we need to have a correction factor. Similarly, they have come something for renal failure and troponin I. So depending on CKMB have no issue, but troponin I will get elevated in renal failure, sepsis and all those things. So what is a significant TROP-I elevation? There is some correction formula. No, some journal have read, but I am not very sure about it. So most importantly, this information what you said, the peaking and how long it will be elevated. That information is very key, because when the patient gets admitted to an ICU and you have given the treatment, imagine this patient, you have given her Clexane and everything, and she is there in the ICU like 3rd day, and you are about to discharge her, and suddenly she is complaining of a chest pain. So there is no point in sending a troponin I again, because that will be always elevated. You have to send CKMB. So that is the idea. Whenever you suspect a reinfarction, after 48 hours, you have to do CKMB. That information is very key. And there are some newer biomarkers that they are from HFAB and all, but it's not been hard fatty acid, something they have come up and all. And it's not been very commonly used these days. So it's not easily available. So these are the 2 standard biomarkers that we have. And now let's come to the treatment aspects. So how will you plan your treatment for this patient?
This patient is diagnosed as NSTEMI. First of all, patient is a persisting chest pain is there.
Okay.
So we decrease the pain with nitrates. Sublingual sorbitrate 5 mg was given. Then there is no tachycardia, there is no desaturation. Then we go with.
You can give morphine also. That's fine. If you find it's typical, you give morphine. Because these days people are hesitant to give morphine because you don't give like 4 mg or 5 mg. You can 2 mg of morphine. Subcutaneous, you can even give IV morphine. So it's a typical only thing you have to give an antiemetic. So the patient will vomit. Anything.
Then we start with injection Clexane.
Okay.
This 0.6 ml IV device.
Subcutaneous or IV?
Clexane subcutaneous. Or you can use heparin.
Antiplatelets.
Antiplatelet. First of all, we give loading dose. Loading dose use aspirin 325 mg given, followed by aspirin 75 mg daily. Then
75 or 150?
75 mg.
See, there are two school of thoughts. Some say initially you can give 150, 300 mg, 150 to 300 mg loading dose, then 150 mg with another antiplatelets. But you are definitely treating that. You can go ahead with even 75. So at the time of discharge, majority of this group of patients will be on dual antiplatelets for 1 year. 75 mg of aspirin or clopidogrel 75 mg, or these days there are newer like ticagrelor. So either of these agents we need to chart, and single antiplatelets will after 1 year usually it's single antiplatelets.
Then we give ticagrelor 90 mg, 2 tablet 180 mg given, and atorvastatin 80 mg, statins atorvastatin 80 mg, loading dose was given. Then we started with Clexane.
Suppose this you have started all this treatment, the patient is still complaining of chest pain. What do you do?
Morphine.
Yeah, given morphine, everything. So that is the time when you need to think that the patient should be taken for an early PCA. So when the patient is symptomatic, even if we standardly we speak PCA, we say it for STEMI. Whenever you have a patient with non-ST elevation MI and patient is still symptomatic, you can do an early coronary intervention and you can see what is happening in the vessel and you can clear it off. There is no contraindication for a PCA. So PCA, when we talk, it is for ST elevation MI. But here, if the patient is still symptomatic, the patient is having ongoing chest pain, the patient has got hypotension, the patient is having features of cardiac failure, why you want the infarction to proceed further? So that is what you need to think of. What is the newer definition of myocardial infarction?
Occlusive MI and non-occlusive MI. Occlusive MI contain NSTEMI and STEMI. Non-occlusive MI contain unstable angina.
Okay.
In occlusive MI, there is near or total occlusion with insufficient collateral circulation causing active infarction. In non-occlusive MI, there is no occlusion or sufficient collateral circulation to the myocardial tissue.
So the treatment varies. So unstable angina, I don't say you want to push for a PCA immediately, but non-occlusive MIs and all, you need to preferably go ahead with PCA and NSTEMI also. NSTEMI comes much as an non-obstructive MI, but still there is a subendocardial ischemia. If the patient is symptomatic, you can go ahead and do. And another important thing, what are the type 1, type 2, type 3 MI? Are you able to remember those things? What is type 1 MI? It's a primary coronary problem that is causing a myocardial infarction. And type 2 MI is what we see in patients with sepsis. And they are developing a myocardial infarction. They are getting troponin elevated, but they don't come with a chest pain to us. That is a primary type 2 MI. So we see a lot of type 2 MI actually. We admit a lot of sepsis patients, they will have some myocardial infarction also. That is called as type 2 MI. Type 3 is a sudden cardiac death, myocardial infarction. Type 4, there are two types. One is immediately after your PCA and after stent thrombosis. And type 5, I think post CABG, they are coming with reinfarction. So these are the different types. So as a postgraduate, you should be knowing what are the different types of MI. Type 1 to type 5 MI, that is I think 2018. There is some universal definition of myocardial infarction, type 1, type 2, type 3, type 4A, 4B and type 5. That's what I remember. So that's a different type, just for the conclusion's sake. And most importantly, what are the complications that you will anticipate in this group of patients? One,
left ventricle remodeling is the
complication. Whenever you see complication, immediate complication, late complications. What are the immediate complications that you will say? Arrhythmias. Most commonly is arrhythmia. They can go for a congestive heart failure. Arrhythmia, cardiogenic shock, all those things is the immediate complication that you will see. And the late complications will be
remodeling.
Remodeling is not good. They can again come with cardiac failure and pump failure and frequent hospital admissions. You can have late complications. And the same patient, myocardial infarction, you are discharging him home and he's coming back with chest pain, pleuritic sort of a chest pain. What is that called? And the treatment is something else. Patient you have discharged, we treated for an myocardial infarction, you have treated him 4 to 5 days later on, maybe 7 days, he is complaining of some chest pain. It is an autoimmune phenomenon. Dressler syndrome. That is what? Dressler syndrome. So that is Dressler syndrome. One of the rarest complications, just the name syndrome, so that I wanted to ask. So what happened to this patient?
After 48 hours, they're taken for angiogram. Angiogram done, double vessel disease was there. Then they planned for stenting the patient.
Okay. So double vessel disease from the ECG, where all will be that vessel that is get affected. To my knowledge, we have to revise, maybe LCX is affected and maybe RC is also affected. You said there is ST segment depression, 3 AVF,
and V4 to V6.
V4 to V4 to V6. Distal LAD lesion or an LCX lesion or an RCA lesion with a distal LAD lesion. That's what I think this patient, we have to just the angio report. We'll know what the lesion is all about. Okay. A single vessel disease. Suppose this has come as single vessel disease. Where could be the lesion? I am telling this patient is having a angio done, only a single vessel disease. Where will be the lesion?
LAD.
Circumflex. Imagine maybe a circumflex dominant. It is supplying the inferior wall as well as it is supplying the lateral wall. You said regarding double vessel disease. So that's why maybe if it is circumflex dominant, it would have supplying the inferior wall also. And if it is not circumflex dominant, it is the distal wall is supplied by the LCX and this side by the RCA. That's how I guessed. Let's see what is the report of the angiogram. You have anything else to add on? Okay. So primary thing, what I want to just say that 3 things you need to remember. If you see ECG, normal ECG, and even the cardiac enzymes are not normal, don't send them home. Only history is enough to diagnose a myocardial infarction. It's an unstable angina. So keep them under observation 24 hours in the hospital and you do the risk stratification with your whatever the scoring system. There are a lot of scoring system for risk stratification. Then depending upon that, you decide what needed to be done next. So 3 things are always there. History, whatever be the definition you call, history, ECG, and your cardiogram. These are the 3 things that is required for the diagnosis of an MI. Okay.